Our ASH 2015 coverage continues. I'm Thomas Baldrick. Happy to have with us now Dr. Naval Daver from the MD Anderson Cancer Center in Houston, Texas. Thank you, sir, for coming by. Busy times right now, huh?
Yes, it's good. It's busy, but a lot of exciting stuff coming out right now at ASH. So we're all very excited in leukemia community.
Let's talk about one of your studies, Azacytidine in combination with Ruxolitinib for patients with MDS and MPNs. What was the purpose of this research?
Sure. So, as in MDS, MPN is a kind of a new entity. Most patients in the past have been diagnosed with either myelofibrosis, which is a fibrotic condition of the marrow, or with MDS, which is myelodysplastic. Now, in the last 5 to 8 years, there's been increased recognition that there's about an 8 to 10% group of patients who have features of both myelofibrosis and myelodysplasia, both on the bone marrow morphologically, as well as based on the mutational profile. And there have been some nice papers recently published from some of our colleagues, Mike Savona and our group on this. So one of the things that has never been done actually in MDS MPN, since it's such a new diagnosis, is a frontline clinical trial to address this condition and see that does it behave more like MDS in treatment responses, does it behave more like myelofibrosis? And so what we did is we used the two drugs that are best active in MDS and in myelofibrosis. MDS is azacitidine, myelofibrosis is the Jakafi, and they're both approved respectively for these conditions. And we thought if we do a combination, reducing the doses of both, we may be able to get improvement of both features, dysplastic and fibrotic changes. And that was how the inception of this protocol happened.
And how did the results match your expectations?
So the results are very encouraging. Now, one of the things with such a relatively rare disease and a new diagnosis is that the historical controls are not well established. So we don't have very good historical data on what is the MDS MPN outcome. There are a couple of papers, one from our group that Dr. DiNardo has published, which shows that in these MDS MPN unknown, which is a subset of the overlying MDS MPN, the median survival is about 12 months, and in our study we're looking about 18 to 20 months, which is good. The other thing that we saw is that patients who had more myelofibrotic features, so a bigger spleen and more symptom burden at presentation, seem to respond the best. They have a very quick improvement in their quality of life and spleen shrinkage. 8 out of 9 patients, in fact, had a spleen shrinkage. And that suggests that especially in the patients who have a fibrotic predominance, this treatment could be one of the ideals. Now, what we did see is in the CMML, which is another group of MDS MPN, the response rate was equivalent to what we would get single agent Vidasa, which brings us to the question that maybe the CMMLs behave more like a MDS kind of disease, and the Rux or the Jakafi does not add as much. But we're talking small numbers because we only have 25 patients in this study. It's a single center with a relatively rare disease, and what we would like to do is see if other centers are interested, and we are in discussions with them to kind of expand it to a bigger study with multiple centers and get more robust data.
Do you think the number of MDS MPN patients are growing, or just the recognition?
I think it's recognition. I think this is the same thing that happened about 11, 12 years ago with myelofibrosis itself. A lot of people didn't think that, or argued that whether there was such a thing as myelofibrosis or it was just aging-related bone marrow changes, etc. And MDS also went through the same thing about 15 years ago. And as there was increased recognition, and most importantly, actually, once there was a good treatment with Jakafi, and of course now with other JAK inhibitors coming, that is really what made patients start going online, finding out what's going on, go to centers such as MD Anderson and Mayo and Sloan. And I think those are the two keys: improve recognition in the medical community between hematopathologists and hematologists, and then effective treatment. And I think that's why this data will hopefully make patients and physicians know that this is a condition, there is a treatment, there is a trial. This will help the physicians learn more who are doing the trial, and it'll help our patients, and that's the idea.
Safe to call this study a good start?
Yeah, yes, absolutely. It's a novel disease, now recognized, and has a treatment that has good activity, and we need to build on it.
Very good.
Yeah.
Thank you, sir. We wish you luck.
Absolutely. Thank you. Yeah.